am Christos Papanikolaou, the CEO of Optohellas Group, and today I welcome you at OptoTV new episode. I am honored and happy to have together consultant pedo-ophthalmologist Dr. Damien Yeo, one of the most important key opinion leader in pedo-ophthalmology. Dr. Yeo, welcome in Greece, welcome to our family and to OptoTV. I will be more than glad to have this interview today with you.
Thank you, Christos. It is a pleasure to be here.
Dr. Yeo, good morning one more time, and I want to ask a very simple question for the start. Please tell me about yourself and what exactly you are doing.
Thank you, Christos. Thank you for having me here in beautiful Athens, and it was lovely to have met you and your wonderful team. I am a consultant pediatric ophthalmologist working in the UK, and I'm passionate about the digital revolution of modern ophthalmology.
The first question was too easy, I believe, so I have to make it a little bit difficult. Tell me more about that. What is your take on the modern eye examination by the modern ophthalmologist?
Well, in the last few decades, we have seen faster and better machines that are capable of performing non-invasive, high-resolution scans and pictures of the eye, from the front of the eye to the back of the eye. The data it collects is exponentially increasing in quality and speed. In some cases, the data collected from the machines have so much detail that we don't know what to do with it yet. So the modern eye examination is therefore no longer just a doctor sitting on a slit lamp holding a lens. It is the ability to use and interpret data from ophthalmic machines that can quantify and monitor both structure and function of the eye. And all of this done within the clinic environment.
This is interesting, very interesting, but now I have a very precise question. Do you think this will de-skill an entire generation of ophthalmologists?
Well, I actually think it's the opposite. I like to think of it as changing skills rather than losing skills. So let's use an analogy of the sat-nav and paper maps. When the sat-nav first came out, many people were slow in picking it up. But as the technology started to improve and became more and more accessible and now easily available on our smartphones, our ability to get to our destination using a sat-nav has exponentially improved. So when was the last time you remembered getting lost if you had your Google Maps on? And from a patient perspective, what is the most important? The clinical outcomes. So in my example, so let's use the analogy, the patients are the passengers of a taxi and the taxi driver is the clinician. Do you want your driver to have a sat-nav? Or do you want your taxi driver to be very good at reading a paper map? So realistically, as a passenger in a taxi, I don't care how good you are at reading a paper map. Even if it's taken you many years to gain that skill, I'm very interested in getting to my destination safe and on time and good value for money. And so a taxi driver with a sat-nav will be able to do that every time and also find the quickest route, avoiding traffic jams. So patients, they just want the best outcomes for them, and validated technology allows us to provide that.
As I understand, you are a big supporter of tele-ophthalmology and maybe artificial intelligence, Dr. Yeo. How do you see this evolving over the next few years?
Well, I think tele-ophthalmology and remote care will be important for two reasons. The first is for the convenience of patients and clinicians. Remote care saves us a lot of time and money. Now, our patients are busy people with very important things to do. Remote care can cut down unnecessary travel. It also empowers patients who live in rural areas. Secondly, tele-ophthalmology, on top of being able to deliver remote care, also allows us to digitize data. When you have clinical information in a digital form, you can do a lot more with it. You can save it, look at it again if needed, and analyze it, all within a digitally safe environment. And this touches on your questions about artificial intelligence. Artificial intelligence depends on good quality data. As human clinicians, we have such a short reach. We only can do so much at any one time. But with tele-ophthalmology and artificial intelligence, it allows us to have a much bigger reach. We have a lot of digital arms doing many things at the same time.
You have previously wrote about this. How do you use imaging in your clinical practice?
Thank you. This is one of my favorite topics. I use imaging for almost everything. Any clinical sign that can be visually discriminated, meaning we can see it and identify it, should be photographed or videoed, in my opinion, or captured on the machine. Even normal findings of the eye are important to capture because it gives an idea of the structure and function of the eye at that point in time. I take photos and images of everything, from the front of the eye to the back of the eye. We're talking about eyelid lumps and bumps, anterior segment photographs, videos of eye movements or neuro-ophthalmology findings, photos of strabismus of different positions of gaze, and of course the many, many types of images of the posterior segment of the retina and all the different modalities. If you have an ability to take a photo of a clinical sign in clinic, but instead you don't do that and you do a little drawing on a piece of paper, you are doing such a disservice to the patient. The challenge really is that in most clinics, we are not set up to collect photographs and images effectively. It is time consuming. Hence why many ophthalmologists around the world are still doing diagrams as part of the clinical notes. So what we need to do is, the technology is there to take these photographs, but what we need to do is to invest in the infrastructure to facilitate high volume imaging in the eye clinic. There also needs to be a cultural shift, and this can sometimes be one of the hardest things to achieve in medicine.
Dr. Yeo, you are one of the most important key opinion leaders in pedo-ophthalmology. Let's talk about pediatric ophthalmology, which is your subspecialty. What have been the recent advances?
Well, it is an exciting time to be a pediatric ophthalmologist. Firstly, the diagnostics. Advances in genomics overall have really carried over some major progress in pediatric ophthalmology. Whole genome sequencing tests are now much cheaper and more accessible, allowing patients to receive a molecular diagnosis years earlier. As things like the camera acquisition gets a lot faster, we are now learning how to capture clinical data from younger and younger patients, even babies. For example, when we use the ultra-wide field cameras or portable OCTs. When we have the ability to diagnose children much earlier, we can impact their lives much sooner and for much longer. And secondly, in terms of advances, the therapeutics. Just not so long ago, when a child is diagnosed with a retinal dystrophy, we were still using the words "no cure" when explaining the condition to their parents. But now, for a particular type of Leber's congenital amaurosis, which is a type of retinal dystrophy, we can actually inject new DNA material into the patient's retinal cells to stop them from going blind. And this sounds like science fiction, not very long ago. But today, we're calling this gene therapy. So even though it's slow and sometimes the research goes through many cycles before looking promising, in my lifetime, I think we will start seeing more and more gene therapy options. Other examples of very popular therapeutics include like biologics in juvenile idiopathic arthritis, atropine eye drops in myopia, and anti-VEGF in ROP.
On the topic of retinopathy of prematurity, ROP, what are the challenges you see in the field?
In my opinion, as neonatology care improves, younger and smaller babies will survive, and ROP clinicians will start seeing more and more complex ROP. Anti-VEGF treatment also means that their follow-up may end up being much longer. So there will therefore be an increased need for high-quality ROP screening across the world. To do this, there might be a need for non-ophthalmologists to carry out ROP screening with specialist cameras. So it frees up the ophthalmologist to do the important bits, which is the interpretation and the treatment. So I am a big supporter of using contact wide field cameras for the screening of ROP. First, there is no human drawing that will ever beat a good quality photo, even a poor, moderate quality photo. That's why the photos will always trump a drawing. So, and secondly, and we've touched on this, we need to digitize clinical data. If we are keeping everything analog, how do we expect to harness the power of artificial intelligence? So to ensure that ROP care can keep up with the growing demands, retinal imaging is no longer a luxury, but a necessity.
Dr. Yeo, I have one more question, and I believe it has to do a lot with the technological progression in the field of ophthalmology and pediatric ophthalmology. How useful would be for you a portable OCT technology?
Thank you for asking. That's actually one of the advances that I've been looking forward to. So portable OCT allows us to start taking OCT pictures of young babies and small children. This means we can start opening up a whole new world of data in our most vulnerable patients. In what I do in ROP, we look after children who are very premature, and these babies develop something called retinopathy of prematurity. And we've never been able to use OCT technology on these babies because of the way they are situated in the incubator in the neonatology unit. So with a portable OCT that is quick and can produce high quality images, we can start being able to understand and monitor this very serious disease can take away their vision. So that's just one of the applications of portable OCT that I'm looking forward to.
One main important principle in medicine is prevention is better than cure. What do you think, Dr. Yeo, about that?
Yes, I agree wholeheartedly with that. Prevention is better than cure, and this is very prominent in pediatric work. Pediatric ophthalmology allows us to intervene much earlier before the disease sets in, and we all know that the sooner we address a problem, the less complications there will be in the future. Also, some examples for this would be like screening for lazy eyes or amblyopia or strabismus in young children. The quicker we pick it up, the earlier we can intervene, and the better the long-term outcomes. And some other examples are like screening for uveitis in patients with juvenile idiopathic arthritis. If we can address the uveitis before it causes sight-threatening complications, these patients can go on and live full lives without any compromise to their vision. And another very popular one nowadays is myopia treatment using eye drops and prevention strategies such as recommending outdoor activity for young patients at least 2 hours a day. And there is good evidence now that outdoor exposure is protective against the development of myopia or short-sightedness. And if we can prevent patients from developing very high myopia, the risk of them getting retinal detachments, glaucoma, and all the complications associated with high myopia will be reduced dramatically.
Dr. Yeo, it was a very interesting interview, and I'm really honored that I had you here and discuss about all these exciting things in pedo-ophthalmology and the future of digital ophthalmology. I thank you one more time from Optohellas family and Optohellas TV that you were here with us today.
Thank you, Christos. It was a pleasure to be here, and I've had so much fun talking about all these topics that I'm very passionate about, and I would love to come back here again in the future.
Thank you all of you watching OptoTV, the dedicated web channel for optometry and ophthalmology in South East and Middle East Europe. Stay tuned with us, and thank you one more time. See you soon.